Patients hear the words pulmonary function test and immediately imagine something painful, complicated, or frightening. The reality is that this simple breathing test can answer questions that patients have had for years. If you've ever wondered why you become short of breath, why you wheeze, why you cough, or whether your lungs are functioning normally, today's conversation is for you. Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. So, Dr. Shah, I have a patient. This patient is 41 years old, has a history of chronic cough. She tells me that she coughs several times a day, for several days a week, for several months a year. Just feels miserable when these episodes happen. And she also reports some shortness of breath with the cough. And this has been progressive. So she came and saw us as a new patient a couple of months ago. And so we referred her for a pulmonary function test. And when I told her that, she was like, "Doc, what is that? Are they going to hook me up to some machine that will interfere with my breathing?" I said, "Nope, it is painless." But I wasn't too sure, so I brought you to explain this to the viewers and the listeners. What exactly is a pulmonary function test, and what is its relevance to the patient I just told you about?
Yeah, so a PFT or a pulmonary function test typically has three parts.
Mm-hmm.
The newer machines are basically on a laptop and there's no box.
Okay.
The older machines, and they still make them, it's called a body box. So some people will say, "Oh, I got into this box," and they close the door and it's a clear box. And so it's called a body box.
A body box?
Yeah.
That doesn't sound good.
Yeah. Well, it's clear. You can, breathe in there. It's not a problem. But so I just wanted people to know the differences. Now, in our office, we use the laptop type machine. And in a bigger hospital, you may get into this thing called a body box. But there's three features of a PFT. There's one which is called spirometry. Mm-hmm. The second is called lung volumes. And the third is called diffusion.
Okay.
And we may not do all three, or we may do all three. We may just do the spirometry by itself. The reasons for doing different parts of the test, they're measuring different parts of your lungs.
Okay.
In other words, the spirometry is telling us how much can you forcibly move air out of your lungs.
Mm-hmm.
And so that's called a FEV1, and that basically stratifies where are you on the spectrum of COPD.
Mm-hmm.
The patient you mentioned seems to have maybe a chronic bronchitis, a form of COPD. She could also have cough variant asthma as well. So in the realm of asthma, COPD, that spirometry is very important to kind of stratify where they are in terms of how well they're controlled or not controlled, or in the case of COPD, are they mild, moderate, or severe, or very severe. Then you have lung volumes. And basically we're looking at what is the volume of your lungs. In other words, some people, especially with COPD or asthma, they trap air. And what that means is that they are breathing a certain amount of air in, but not breathing a certain amount of air out.
Mm-hmm.
And so we want to know if that's the case. And if that's the case, that could kind of help us make you less short of breath if we treat what we call air trapping. And there's other reasons to do lung volumes. But basically, we're trying to see what is the total capacity of your lungs, what is the volume left over after you take a deep breath, after you take a normal breath. Those kind of things are part of the lung volumes. And then the final is called diffusion. And that's basically how your lungs are taking the air that you breathe in and implementing them into the bloodstream. In other words, going from the air to your lungs to the bloodstream. So how well is that process?
Wow. This is a deep dive into the functioning of the lungs.
Correct.
So you're basically looking at how air gets in there.
Correct.
How it goes through the tissues.
Correct.
And how it lands in the blood.
Absolutely.
Now, why is that important so the patients can understand? Why do we do that? What is the function of the lungs anyways?
Yeah. Well, the function of the lungs is obviously to breathe, and that breathing means taking air in and getting it to your blood, and then taking carbon dioxide out and getting it into the environment.
So the lungs are basically cleaning out your blood. It's like a gas exchange
Right.
between takes oxygen, puts in your body, gets carbon dioxide out.
Correct. Exactly.
Okay.
That's the main function of the lungs.
And so the pulmonary function test examines the different stages of this process
Correct.
to see how efficiently your lungs are doing it.
Correct. So, and it's a static test. In other words, you're sitting there, you're not moving. There'll be a clip on your nose and a pipe in your mouth, and you're just inhaling, exhaling, depending on which test you're doing. And that inhaling and exhaling is telling us something about your lungs. What is the volume of your normal breathing? What is the most that you can take a deep breath? What's the most maximum that you can expire? And these are all giving us parameters of, are we looking at someone that has scarring in their lungs? Are we looking at someone that has pulmonary hypertension or blood vessel issues? Are we looking at someone that has COPD, emphysema, bronchiectasis? All of these things are helping us. The PFTs are helping us determine all of these different factors.
Okay. So let's look a little bit at the various cases
Sure.
that we have in the clinic. A patient who has an asthma exacerbation, short of breath, is wheezing, and, can't breathe. Why do they need a PFT?
In asthma, if you're not having symptoms, typically your PFTs are going to be normal. And so if you're having worsening symptoms, we can kind of have a baseline where you say, okay, these are normal, and now they're very abnormal.
Okay.
And so our treatment plan is based on that.
Okay.
All right. Same with COPD. COPD, the difference between asthma and COPD is basically non-reversible. Whereas asthma, as I mentioned, if you're not having symptoms, you're basically normal. It's a reversible issue. Condition.
How about the person who has asthma or COPD, but has been stable for a couple of years?
Right.
Why do they need a PFT?
We always want to maintain their baseline. And because lung function decreases over the life of a person, and specifically COPD, the lung function declines at a faster rate. We want to make sure that at least once a year, we're getting a baseline PFT.
Okay. So it should be, in people who are stable, they should have it once a year.
Yeah. In other words, if the treatments haven't changed, your symptoms haven't changed, I would still get one every year because there is a decline in lung function per year of life.
Okay. And if you have frequent symptoms, then you get it more frequent.
Absolutely.
Okay. So the PFT is sort of an EKG.
In a sense, for the lungs, you could say that. Yeah.
Okay. Or an echo.
Right.
Okay. Fantastic. Okay. So in the summary, a PFT is a very benign procedure. There's nothing invasive in it from what you just told me.
Correct.
And who does the PFT, by the way? Who does the procedure? Is it the doctor or the...
Well, typically the doctor could do it, but they usually don't do it. Typically it's a respiratory therapist or a medical assistant can also do it, but typically a respiratory therapist who's trained in respiratory and trained in doing the PFTs that is going to be doing it. In our office, it's a respiratory therapist that will be doing it, and so she is trained on how to do the different aspects. In other words, there's a technical aspect and there's a patient aspect. You could totally, as a patient, botch the test by not giving a good effort. Effort is a big part of this test.
Okay.
And then the technical aspect is how, the machines are calibrated and the instructions are given to you. So that it's very dependent on both parties.
Okay. So there is a lot of expertise involved.
Right.
So let me ask you another question that is sometimes a conundrum for us primary care doctors when we want to refer a patient whom we think could benefit from having a pulmonary function test. Should we refer to the pulmonologist like yourself, and then you determine what type of PFT they're going to need, or should we just refer the patient for the PFT and then you see them after?
I would say it's best to, if you're going to do a specialized test like that, there are variations in each person. So based on race, sex, weight, age. So everybody has a set norm based on those factors. But there are nuances as well that I think as an expert you would be more keen to look at rather than say, okay, this is normal, period. This is normal, but the lung volumes are a little this way. This may mean that you're overweight, or this may mean that you have a restrictive lung disease.
Okay.
So I think that it's best to refer to the pulmonologist or the expert and have them kind of do the PFTs. If you get as a primary care, you have an abnormal PFT, I think obviously you should refer out. But even if you have a normal PFT, but there are symptoms, I think that's another reason to refer out.
Okay. So since we are all about efficiency here, it sounds to me like we should do both.
Yeah.
Schedule the patient for the pulmonary function test and refer to the specialist to interpret the results appropriately based on that patient's characteristics.
Sure. Yes, absolutely.
What do you think that's the better approach?
No, I think that's probably the best approach.
Okay.
Yeah. And in terms of streamlining therapies, making them a little bit easier to acquire, I think that would be less time consuming if we do it that way.
Okay. All right. So to recap here, so the pulmonary function test is nothing to be afraid of. It is a very useful test, gives us a lot of information about the functioning of the lungs in breathing, which is the most important function they have to do.
Correct.
And it helps diagnose and treat conditions that otherwise we wouldn't know, as in the case of my patient. It turns out she had really bad asthma. She had asthma as a child, I think it's up to her teenage years, and not really suffered any exacerbation.
Yeah.
And so she stopped using all her inhalers. And the PFT did show that she had reversible obstructive lung disease.
Correct. Especially in asthma, we also often give a bronchodilator, like an albuterol, to see if there is improvement in, when they're using their inhalers. And if we determine that about 200 cc's or 12% improvement, then that's positive test for that as well.
Okay, fantastic. All right. Thank you, Dr. Shah.
Thank you.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.